Well, then, thank you so much for finding the time to talk with me. I hope congratulations on the job.
Thank you so much. It's an honor and pleasure to talk with you.
Well, are you enjoying the job? How's the work?
I am, and
Ooh.
it's a steep learning curve, obviously, but I've been here for almost 4 years now, and so I've learned a lot of the landscape, if you will. So it hasn't been like it's brand new.
Yeah, but it's still probably like drinking out of a fire hose.
Yes, exactly. There is an aspect of that for sure.
Yeah. Any surprises? Anything?
That's very an interesting question, Paul, because I had anticipated more surprises, but really haven't had as many. There's occasional things that, oh, I hadn't heard about this before, and I need to do a little bit more homework and talk to some stakeholders. But surprisingly, maybe those have been not as frequent or as many as I thought. And probably I should really credit Dr. Jennifer Paul, my predecessor, who I think left things really tucked in well for me to assume the position.
Well, how did you decide to apply? How did you put your name in the?
It was interesting. When I got here, so I don't know if you know this, I was at Johns Hopkins for 20 years, and I got here in 2018. And I really came here to kind of jumpstart our precision oncology efforts and co-lead the breast cancer program. But I wasn't shy about letting people know that my kind of goalpost for, I don't know, 5 to 7 years down the line was thinking about being a cancer center director somewhere. I never presumed or assumed that it would be at Vanderbilt. But I think that notion got into Dr. Paul's head. And when it came time for her to kind of ascend into her new role, she made the recommendation and asked if this would be something I'd be interested in. I kind of looked at her and I thought, well, that would be great. And it would mean we wouldn't have to move from Nashville in any time in the future. So, and kind of the rest just fell into place and was history, which was great.
Oh, that sounds fantastic. Well, to quote Joe Simone, which one always should, when you've seen one cancer center, you've seen one cancer center. What's Vanderbilt like?
That is such a truism. And again, as we discussed earlier, I love Joe Simone's maxims. I think when I first got here, I had forgotten that this is a much more traditional matrix organization in terms of academic cancer centers. So we are a matrix center, not a department. We don't do hiring. And at my old place, because I kind of grew up there, the Hopkins or Sidney Kimmel Comprehensive Cancer Center, Johns Hopkins, is kind of a hybrid where they are both a department of oncology as well as a cancer center. The administrative lines are one and the same. Here, they're very distinct. And so that was not new, but kind of reminded me that this is more traditional. I came from University of Pennsylvania for training, where it is also very much more traditional. I think the thing that is great about our cancer center and somewhat unique is that we also have the Ingram family, who are really actively still involved with helping us kind of direct in terms of like where we're going to go, in terms of like where funding opportunities are and philanthropic opportunities. So that's something that I think a lot of cancer centers are, starting to do, and some already have done it very well. But this has really been kind of in our blood from the very beginning. And that's been a lot of fun interacting with the Ingram family on this mission.
Mm-hmm, mm-hmm. What is going to change now? What is the vision, if you were to kind of summarize the vision thing?
I want us to be thought of as the upper echelons of cancer centers, where if you have a recalcitrant, incurable type of cancer, that people think of us and come here for the latest and greatest state-of-the-art diagnostic testing and care. So when I got here in 2018, that was part of what I wanted to build, and have done so in the world of what we call precision oncology. And I think you and I both know that that has many different names and meanings, but we've really built something within a couple of years that allow us to really test all patients, match them with clinical trials, off-label use of therapies, and bring to bear something that I started at Hopkins, expertise through a molecular tumor board, both in person, but also virtually. We have a global one that we started even well before the pandemic. And it's actually, the pandemic in some ways has made it easier because now everyone's much more facile with Zoom. But I think that that's where a big pillar of what I want to grow and build out over the next 5 to 10 years. I used to use the shtick, or still do, that I really want to democratize precision oncology, meaning that it really shouldn't be just the kind of well-resourced, well-knowledged people who have the capability to come to a place like Vanderbilt to get that level of care. I think this could really be pushed out to all corners of the globe, if you will, and allow every patient the kind of state-of-the-art testing and care that everyone really deserves. And that's a big area that I still want to continue to invest in and push. There are other areas, of course, as well. One of them is in cellular therapies. I think unless you've been sleeping under a rock for the last 10 years, people recognize that this is really the future of our business. And we're really at the beginning, especially in terms of solid tumors and CAR-Ts and other ways to use engineered immune cells and non-immune cells. So that's another area of focus that I really want to build here and make this place the center really to think about if you're going to consider cellular-based therapies for cancer. And then there's a whole host of other things that we have done extremely well, but I think we need to still continue to build on. Our basic sciences here is phenomenal, and I want to really continue to build on that and capitalize the strengths of basic sciences. We actually have, I think this is publicly announced, but please check beforehand.
No, this is fascinating.
John Currian is going to be our new Dean of Basic Sciences. He is a Howard Hughes investigator, National Academy member from Berkeley, and he will be starting here January 1st. And so he's going to bring even more credibility and kind of gravitas to the whole basic sciences field. And he himself does work in the cancer field. So again, that's really exciting for us to have someone of his stature and magnitude be our next Dean of Basic Sciences. And then similarly, clinically, the clinical research, our clinical reputation continues to grow. But we're also really trying to push that out to let people know, beyond the precision oncology efforts, the level of expertise that we have here, and that really make this a tertiary quaternary care cancer center where people will come, get additional opinions, but maybe now with telemedicine, telehealth, even continue their care here remotely. This is an opportunity I think that many hospitals and beyond cancer are looking at. We, like many institutes during the pandemic, have started a kind of hospital at home program where traditionally these patients would still be on the inpatient, but now they're actually at the comfort of their own home and we can monitor them remotely. Our stem cell therapy group here has really led this charge in cancer where we're doing a lot of transplants now in stem cell therapies at home. This was just published, and thinking about, capitalizing and leveraging technology like wearable monitors where you could have 24/7 monitoring from your home that we could actually monitor remotely. Those are kind of the ideas, and pushing out how do we actually get care, to use my prior phrase, democratize cancer care for everyone, so that if you need really specialized care, you can get it, but you might not have to travel, across the state or even across state lines, that this is something we potentially could do in a hospital at home situation.
No, it's fascinating, but maybe we should just back up a little bit. What catchment area? Is it the state of Tennessee, or is it more?
It's more. We're actually the whole state of Tennessee, a little bit of Kentucky, and a little bit of Alabama. And so that's where we have opportunities. If you look at our kind of cases and where they come from, Dr. Petenball has this great slide where it's really based upon the highway infrastructure, believe it or not. And so all the highways that are in the state of Tennessee and a little bit around kind of converge in Nashville, which is our state capital. And so it allows people to just quickly get on, travel, and come to Vanderbilt.
Fascinating.
Yeah.
So you're also, Tennessee has a strong oncology presence, including really research capability. What can Vanderbilt do that is different from that group, or even if there's nothing wrong with doing the same things? But
yeah, I think it's a little of both, Paul, to be honest. I think there is some overlap, and I think competition is healthy when it's the right amount of competition. I didn't realize also till I got here that music is not the #1 industry in Nashville. It's actually healthcare, with HCA being headquartered here and many others. Yeah. So that presents opportunities and challenges because it is a very competitive healthcare market. But I also think it allows us to really go across the aisle and work together in multi-partisan ways, if you will. As an example, when I first got here, one of the things that I did is reach out to the people at Sarah Cannon, and we had a meeting about where we could actually synergize. And so, when we have our molecular tumor boards and we're discussing cases, if there's something that there's a trial at Sarah Cannon that there is none here, that's something that we're gonna, say, hey, we don't have this trial for your molecular alteration, but Sarah Cannon does, and this is something that we would refer to them. And that has actually happened on some of our cases. It's a really funny story because a company came up to us and they said, we're looking for these rare genetic anomalies. We looked at our past data. We didn't have a single one in the past year and a half. And so we said, well, we'll refer to Sarah Cannon because they have the trial open. The next year we had 3 of those cases.
Oh, fascinating.
Yeah, but it's all about the patient, so that's okay. And we are really, reminds me and likens me to the story of the Miracle on 34th Street. I don't know if you ever saw that, where the Santa Claus is like, oh, we don't have this, but this department store across the street does, so you should go there. And I think that that's kind of, and it'll work to their advantage in that story, and I think it'll work to us. We're about the patient, and we want to do what's best for patient care. The other opportunity that we have because of Nashville and Tennessee, you probably know that Meharry Medical College and Tennessee State University is right here as well. And that allows us to really collaborate. We have the longest standing U54, collaborate both scientifically and clinically to really try to help our catchment area and demographics that we traditionally might not have the opportunity to. And that is another pillar of mine, is that and again, I know this is kind of ubiquitous now, but I'm very, very cognizant of increasing our awareness for DEI at all levels. When I was the division director of HEMOC prior to this job, I started a diversity committee that really included many of the cancer center members already, learners, staff, et cetera, and to really kind of put teeth behind our program for DEI. So I piloted a consultant when I was division director at HEMOC, and that's something that I'm going to continue to do to really try to get this front and center for everything we do. Again, not just hiring at the faculty level, which is a priority, but even hiring staff, bringing in new learners, and talking about what are the issues that we need to address being here in Nashville, some of which are, again, global for the state of Tennessee and our nation in general, but some are unique to our city and our institution, as well as our catchment area.
Fascinating. How about Memphis? There's the University of Tennessee is getting going. So that's kind of fascinating that's happening there. And how do you see all of the sort of the pieces of oncology business interacting?
Yeah, that's a great question. We have several models of how we work together with other institutions, other hospitals, et cetera. One of which is our Vanderbilt Healthcare Affiliated Network. So Baptist is a partner in that, and we have had a longstanding kind of relationship with them and continue to do so. This includes things like they join our tumor boards. For example, Dr. Phil Lamners, who was a Vanderbilt or is a Vanderbilt alumni, but trained here. He is there and really our point person when we discuss how do we actually interact, how do we synergize. And so he has actually presented many cases to our molecular tumor board. And they remain an active partner. We're doing clinical trials with them. We have some research agreements with industry sponsored trials with them as well. And it really runs the whole gamut. But a big component of that, as I think you're alluding to also, is that it allows us to capture more patients who are our constituents. These are patients that we really want to help, and we might never be able to have the opportunity to help them if not developing relationships across the state in our catchment area.
But what can you do that others can't? I mean, there is an answer to this. There are things you can do others can't.
Well, I think there's again, I'm trying to be humble. Yeah, there's a lot of things that I think we have unique expertise in. I already mentioned the precision oncology efforts and bringing together our experts at our molecular tumor board, which really does afford an opportunity to get insight into the world's experts, not only for their diseases, but also for the molecular alterations associated with them and how we can actually make recommendations That's something that not a lot of academic and even community and even academic centers really have. And so that's something that I think we're really excelling at. I think there are other things, obviously clinical trials, investigator-initiated clinical trials, especially because those are things that for-profit entities don't do a lot of, and a lot of the stuff that we have is kind of homegrown. As an example, from our spore, our breast cancer spore, we had a trial led by Doctors Ingrid Meyer and Carlos Artiaga looking at, hey, could FGFR1 amplification be a mechanism of resistance to endocrine therapies with CDK4/6 inhibitors? And so that was a trial and a hypothesis that grew out of our lab, was put to the test. And even though the study was in fact negative, there's a subset of patients that look like they had really high amplification that may actually lead to future thought about how do we recraft our hypothesis. Science is always a reiterative process to see if those are individuals that we could actually do something about in terms of targeted therapies for the future. So those are great examples of how we can leverage our really phenomenal basic sciences here at Vanderbilt and then turn them into real meaningful clinical trials. There are also huge efforts. One of my areas of expertise is liquid biopsies and circulating tumor DNA, but that also exists here across the board. This is something that as a breast cancer oncologist, I focus mainly on that, but it's been great fun interacting with our lung cancer colleagues, our melanoma colleagues, to figure out how do we really expand the space in ctDNA and put more clinical utility behind this. Right now, I think we're all in a space where we're using the qualitative aspects of ctDNA, meaning, okay, if you have this mutation that we find, you could get this drug. But we're really pushing on now, as are others, to use the quantitative aspects, things like early stage cancers for minimal residual disease. And then what do we do about that? As well as in metastatic disease, can we actually use ctDNA to guide a change in therapies earlier rather than later and afford a better outcome for patients with metastatic disease? And then lastly, I think we have the best, in fact, I think we're rated the best, Department of Biomedical Informatics in the country. This is something that is a huge strength of Vanderbilt, and one of the reasons I came here. By comparison, many places don't even have a Department of Biomedical Informatics. And I didn't realize that REDCap was invented here by Paul Harris until I got here. And so we have a lot of fun tools that are kind of exclusive to Vanderbilt. We have this amazing biobank database that has collected, it's called BioVU, it's collected patients, kind of germline genetics from 2007, and we have all this follow-up. This really gives us insight to do things like, hey, what are the genetic predictors of toxicity, of side effects, as well as efficacy? Who's more or less likely to respond? This also gives us great kind of leverage for health informatics in cancer and just across the continuum of academic medical care. So as an example, one of the things that we did for precision oncology, and this was led by colleagues Travis Osterman and also Christine Michael, we were the 8th institution to get the EPICS genomics module. And so what that allows us to do, and even though this sounds so simple, it's really not, we now can just directly order testing, NGS testing, and it goes straight to our vendor, and then we get the results repopulated, not as a scanned PDF, which is what normally happens. This is discrete data that comes back in, and it's treated and looked like just like any other test, like a blood count test. And that allows us to search it. That allows us to kind of immortalize it and do research on it as well. And that could not have happened in the cadence that it did here at most other institutions that I'm aware of. And it was funny, I gave a talk about this at my old place, and afterwards people came up to say, hey, we want to come to do a sabbatical to learn how you did this so we can implement it here. And it's been really phenomenal. It has allowed us to do things. For example, we have a program now where if a new drug gets FDA approved for targeted therapy, we can go back very quickly and say, okay, how many patients have metastatic disease to meet this criterion? How many patients are alive, obviously? How many patients have the genetic alteration that now we can allow or contact them and the provider and say, hey, you know what? This drug just got approved and you're eligible for it. that's really powerful because historically, once a new drug gets approved, it takes years, sometimes a decade, before it's widely disseminated and implemented. And so
And
this
this
allows us to really shorten that gap.
and you're doing it through Epic, through
Yeah, yeah,
like the same Epic that does
yeah. It's surprising, right?
yes. Electronic medical record. It should be a part of the electronic
Yeah, yeah.
record.
But it is so difficult to search for results from NGS vendors because almost all institutes right now, with very few exception, and we're one of them, you get the fax. This sounds so ridiculous, right? You get a fax, you print it out, and then you have to scan it in again to
Oh my
Epic.
God.
And then it gets, yeah, and then it gets lost in the media tab in Epic. And I don't know if you've ever seen the media tab in Epic, but it is really finicky and hard to navigate the actual PDF forms.
PDF forms and
Yeah, so this has been game changing for us.
wow. Oh, that's fascinating. Well, I was kind of building up to the idea of equity, of access, and that's something that you can do probably better than anybody. And that's something that's front and center in terms of your own career. So
Yeah,
maybe we should talk about that.
no, I think that's absolutely true. You know, one of the things that when I was at my old place, I was asked to be on the cancer center's diversity committee, and I looked at the individual who was asking me this, and I said, that doesn't make sense to me. I'm an overrepresented minority in medicine. And she said, actually, for leadership positions, you're not, and even faculty positions. For Asian Americans, really hit a glass ceiling quickly in terms of leadership positions. In fact, some people call it a bamboo ceiling. I don't know if that's politically correct anymore or not. But when I looked around the institution, I realized it's absolutely true. There weren't, at least at the time, this is like, almost 20 years ago, there weren't at the time many Asian faculty just to begin with, and let alone Asian faculty in leadership positions. And it struck me, and I've had conversations about this with others who are also Asians, and we compared stories. And one of my colleagues even said that when they were discussing it at a senior leadership level, someone actually said, well, that's because Asians don't want leadership positions. They want to be in the trenches and really work hard. And he said, I almost fell out of my chair. But it's that kind of false information that really, I think, permeates everything that we do in DEI, and the lack of awareness. This is one of the things that I've learned being here and creating my own diversity committee and inviting speakers. We do not do a good enough job to actually think about this and be intentional. My favorite example was I was asked to chair recently a search committee for one of the division directors in the Department of Medicine. And we went around and we contacted our friends and friends, and we came up with mostly white males, senior white males, and they were all really good and qualified. But we had to, like many search committees, had to kind of pause and say, okay, what's going on here that we're not getting a diverse pool? And some people would say, well, it's because there just aren't that many. I think that's a cop-out. That may be true, but there are really great qualified candidates. And so we had to just be more intentional, dig deeper, get more friends of friends. And when we handed our list to the department chair, I was pretty proud of it. We had initially in first pass, we had one woman. We ended up handing a list that I think was 3 women out of the 5. We had an LGBTQ QT candidate. We had Black Americans. We really ran the gamut, and they were all great. When they actually came for in-person interviews or Zoom interviews, everyone loved them, and it was really tough to make the decisions. But it was something that taught me a lesson. And again, I was so glad that I'd started the diversity committee in HEMOG and invited these speakers to really teach me and learn from, hey, because that was the one thing I kept asking, how do we keep momentum going? Right? Whenever there's something that is horrific that happens in our country when it is related to, health disparities, killings, etc., I think we all have heightened awareness and we mean to do well, but then it kind of fades away. It's almost like the sinusoidal wave until the next event happens. And so that was my question in charge. How do we keep the momentum going. And I was told you have to continue to bring awareness. So in every talk that you give, say something about it. In every interaction that you have, say something about it. And she was exactly right, because even with that, when I gave our monthly divisional meetings, sometimes I would forget, and I would charge my senior leadership to remind me. And so inevitably someone would, and I said, oh, that's right, we have to mention something, like we're planning something. And so that to me is really important and high priority. And that's also something where I want to build on. We're actually going to come together soon, talk with all stakeholders, kind of get what people want to see and the directions that I also want to go in, and then formulate a strategic plan of how we're going to get there.
Oh, that's fascinating to cover for us. When you do that, maybe there are lessons others can learn from it. But I was also, DEI is very important, but I was also building up to a question about therapies that might cost more, like CAR T cell
Yeah.
or next-gen sequencing and liquid biopsies and PD-1, PD-L1. All of this, is this going to be just for rich white people, or is this going to be for
No, yeah, it can't be, right? That's the real answer, is that is not the way that any of us want to be in terms of drug development and cancer therapy and cancer care. We have a long way to go, and it's a huge challenge, but it also presents opportunities. And I don't have the answers right now. I don't think anyone does. But one of the things that struck me, to your point, one of my faculty said to me, Ben, we're a victim of our own success, because every time we get a new diagnostic, a new therapy like CAR Ts, it creates a new healthcare disparity. And she was absolutely right. I mean, you think about that, it was really incumbent upon us to start thinking about this, not after the FDA approves the drug, but way beforehand. And so one of the things that we've done as senior leadership, when I was with the division director of HemOnc, and as I transitioned, we're having talks with industry folks right now. And I've asked these very questions. It's like, what is your policy and philosophy about healthcare disparities, equity, et cetera? And have you thought about them? What does your program look like? And how can we work together to help narrow that gap? Not, again, after the drug's approved, but even from the very beginning. So that's a huge, huge push right now. I'm also working with a company called EQRX. I don't know if you've ever heard of them.
Yes.
They're small biotech. This is kind of their whole shtick, right? To make targeted therapies and new cancer drugs affordable. And not just, in this country, but across the world. And I love that concept. And so that's something that, again, I feel very passionate about, and why I'm working with that company.
Fascinating. So, but that also, not so much EQRX at this point, but that issue about drugs that are developed originally in China, that's been very controversial
Yeah.
on many levels.
Yeah, no, it's funny because I totally appreciate, I don't know if you'd call it politics or the controversies that surround a lot of the issues that we've seen over the past few years. I'd like to think, and maybe I'm naive in this, that cancer is kind of the great equalizer. That when you have a loved one or you yourself have cancer, a lot of this goes out the window, because what we're really trying to do is help people. And I think that is my overall charge in life, is to help people. One of the most poignant conversations I ever had was with Marty Abelhoff. I don't know if you knew him when he was
I knew
cancer
him.
director. Yeah, just a great man, and someone I really try to emulate, and was my role model. But he once said to me, Ben, I didn't become a cancer doctor to take care of well people. He said, I don't mean that to, minimize people who do a lot of well care visits, but, for me, it's the challenge of curing cancer and really taking care of patients. And so I do feel like that's something that's higher than politics, higher than controversies, that it's all about patients. And for me personally, it's also about promoting people within our whole center and helping them as well, whether that's my, laboratory technician, graduate students, postdocs, the people I work with here on the administrative side, faculty, et cetera, I want everyone here to feel valued, and I want our patients to feel like they are our number one priority. And I may not agree with their politics. They may not agree with mine. There's lots of, again, more global issues, as you pointed out. But I do think at the end of the day, we need to come together and put those things aside to get to the business of curing cancer.
Yeah, speaking of which, also you're involved in the global cancer institute.
Yeah, that's right.
But you and Don is on, and
Yeah. Do you know Don?
yeah.
Great.
Yeah. So, what can we talk about that for a little
Sure.
bit? What you can do now as director of a major cancer center as part of that initiative?
Yeah, absolutely. One, I think to bring awareness, just like I was saying about other issues, that this is something that I think a lot of people are peripherally aware of, but maybe not necessarily as in the weeds as the Global Cancer Institute is. And so it's a very difficult thing. I'm sure you can imagine that when we started this, Paul Goss was leading this effort for Massachusetts General Hospital. And Don and I were part of the original kind of breast tumor board that he had initiated with low middle income countries. And it's very striking, the standard of care here that we would then say, oh yeah, this is what we would do. Said, well, we don't have access to that drug. We don't have access to that testing, et cetera. That's really eye-opening and challenging. And even though, again, peripherally, I think I was always aware of that, to hear that, when you hear these really horrific cases of young women with metastatic disease, knowing that if they were here, we could actually do a lot for them, but they can't. They don't have access to that type of stuff. And so we're trying to chip away at this slowly. And one of the things I think I can do as the center here, and then also helping with GCI, is to try to bring some of the stuff that we've learned and kind of implemented in our diagnostic testing to the GCI. So as an example, Don and I, our big push right now is, can we get germline testing for these low middle income countries? Just make it universally accessible. I think that a lot of people would say, well, how do you do that, et cetera? Even if you can get the testing for everyone, what do you do with that information? And so our thoughts on this is that, one, well, we could use our global tumor board to adjudicate results and to help our colleagues in taking care of these patients. And two, even though we might not be able to get the latest, greatest therapies like PARP inhibitors and immunotherapies for, Lynch syndrome patients, what we can do is at least suggest what therapies may or may not work that are more traditional therapies like chemotherapies, but also do the cascade testing to make sure that people are aware so that they can get screening, even if it's a physical exam, not necessarily a CAT scan, so that they can actually be aware and try to catch things earlier and know that they're at risk. I think, I once heard Mary Claire King say that, she was pushing that we should all be sequenced and know about potential pathogenic germline variants that predispose to cancer. She said every BRCA1 or 2, and I'm paraphrasing here, patient that comes with a diagnosis was an opportunity lost. And that really has stuck with me and resonated with me. And I personally think she's right, and that we should be sequencing people so that we can know who's at risk and really offer the opportunity to intervene with screening earlier.
Yeah, we've all heard her say that, of course.
Yeah. Not everyone agrees, but
yeah, no, it's I read somewhere, I think it was one of the internal publications at Vanderbilt about your patient from Bangladesh. Maybe we could talk about her last, and then
no, that's a phenomenal story, and really something that grew out of or was part of the GCI. This was circa about 2016, and I'm not very religious, but this story makes me believe in divine intervention. And it was at a GCI breast tumor board, and our colleagues in Bangladesh presented this case of a young girl who had this very rare type of breast cancer called juvenile secretory breast carcinoma. It's much more like a sarcoma than it is a traditional breast cancer. And as the name implies, it usually happens in children and young adults. But, this is a clinical breast tumor board, and I'm the only geeky physician scientist on the breast tumor board. And so normally these are cured with surgery, but unfortunately, I think she was diagnosed as a fibroadenoma originally. The tumor came back several times and then it widely metastasized. And I was the only geeky physician scientist who had ever even heard about this cancer before, and remembered about 10 or 15 years prior, there was a cancer cell paper that actually demonstrated or showed all of these have this characteristic fusion, translocation of ETV6 and NTRK3. So the fate part that was weird was, at the time, I was sitting on the scientific advisory board of a small startup company called Loxo Oncology, who you've probably heard of.
Yes.
And they were looking for these patients. You know, they had a trial at several sites, including here at Vanderbilt. Well, we did not have it at Hopkins at the time. And so I said, okay, chemotherapy, radiation doesn't work in this disease. They'd already tried it. And she had widespread lung mets. And this has all been published now. So she ended up going, we got her tissue samples. I got them. I sent them to MSK because that's where the closest trial was. And she got flown over with her parents, as well as an interpreter. And she got on the study, and it's in the publication. But when she came, she had this almost basketball-sized tumor on her left chest, and her lungs were just riddled with metastasis. And she gets on what is now called larotrectinib, but back then Loxo 101, and within 2 months, everything's gone. And she's still alive today. And that's the most incredible story. She's a young woman now, so what, 6 years later? And I know for sure she would not be here today had that moment of fate not intervened. That's when this light bulb moment went off in my head, Paul, about what we could do with the internet and social media and reaching out to patients, and what I've now evolved to calling democratizing precision oncology. You know, how many patients are out there like her that we could help today, but they don't know about testing, we don't know about them. That's where I want to really bridge the gap.
Well, that's where Mary Claire King was right.
Yeah. If we test people, we will find things that we can actually do something about.
So basically, this was not a wealthy family either, or was it?
No, yeah. It happened to be that the company had a foundational arm so that they would actually be able to reach out and get those patients.
And the company benefited too, probably.
Yeah,
Immensely.
a lot, because Lilly bought them out, as you probably know, in 2019.
So
No, it was a phenomenal SAB, and I learned a lot. I think we all learned a lot, and we all felt like at the end of the day, we really made a difference and an impact. And I think that for me, that's, again, was a pivotal moment in my career about, wow, we could really help a lot of patients. You know, one of the stories I like to tell, or the analogies, is that there are a lot of people who are naysayers, and they said, well, you know, if you did 100 patients, you're not really going to show much effect. I think we have to start rethinking about the whole notion of clinical trials as related to precision oncology, because that's the whole point. We're individuals, not populations. And it's probably, you can't compare breast cancers that have very different molecular alterations. It's kind of like the old days where we just lumped all breast cancers together without knowledge of receptors. And so I think right now, the way I like it is we're at our infancy, but there's this great story about, do you know the story about the boy on the beach and the starfish?
No.
I often tell this story. So this is precision oncology to me in a nutshell. It's a story of the little boy. He's walking on he's on the beach in the morning, and he's throwing starfish into the ocean. And there's a man, he walks up and he says, what are you doing? And he says, well, I'm throwing the starfish in the ocean because, you know, the tide's gone away or come in, and they'll die unless I put them back in the ocean. And the man looks around and he said, there are thousands of starfish here. You're not going to make a difference. And the boy thinks about it, and then he reaches down, picks up one starfish, and he throws it in the ocean. He said, I made a difference for that one.
Mm-hmm.
And that's really the crux of where we are. I mean, I do hope at some point we can save all the starfish, but for right now, there are people whose lives we can really affect a big positive difference and change in. And we got to find those patients, we got to tell them this exists, and we got to help them. So that's kind of the vision I have over the next 5 years for precision oncology. We've set up the shop, we've got the Epic Genomics module, we've got the health IT, we're ready to go. And you know, phase 2 of what I like to call this, really spreading this out and leveraging technology and information to get that out there in a way that's really going to impact. And at the same time, I think as a director in the cancer center, people hopefully will be like, wow, look at what Vic is doing. This is amazing. And let's join. Let's all work together and start really feeding into this.
No, it's fascinating. I'm glad we actually built up to this point. Is there anything we forgot? Anything?
I don't think so.
I think we covered a lot.
Yeah, again, I tend to talk too much, so I apologize.
No, this is not too much. This is great. Thank you.